Cultural competence and cultural safety. Hi, and welcome to the final module of this course. In this module, we will briefly talk about cultural competence and cultural safety. Researchers and academics have proposed these two concepts as a means to address the cultural gap discussed in previous models. There are strategies to assist in providing cultural congruent services. Let's take a closer look at each one of them. To begin, we would like to point out that there is much confusion and ongoing debate about how cultural safety differs from other concepts like cultural competence and cultural awareness. Each of these terms has many definitions, and it is difficult to gauge how they overlap. Several authors, however, have declared that these concepts are not static and rather function as a continuum. Irapeti Ransdem, a Maori nurse internationally recognized for her work on cultural safety, argues that cultural awareness is the beginning step in the learning process, which involves understanding of difference, while cultural competence is an intermediate step where self-exploration of the student is further developed. Cultural safety is the final outcome of this learning process. Cultural competence emerged as a framework for addressing diversity and inequality in the US in the 1980s, and has been defined variously as a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals and enable that system, agency, or those professionals to work effectively in cross-cultural situations. According to Kiermaier, the aim of cultural competence is to make healthcare services more accessible, acceptable, and effective from people from diverse ethnocultural communities. In practice, cultural competence have been applied at two levels: institutions and practitioners. Some examples at the institutional level include institutional policies of cultural diversity awareness, cultural diverse staff, and engaging communities in policymaking. Examples at the practitioners level include ethnic matching of clinician and patient, and the use of cultural brokers or translators. Some medical curriculums have implemented cultural competence training in their programs with motivating results, such as reduction of healthcare disparities, satisfaction and increased adherence to prescribed treatments, a healthier doctor-patient relationship, and even improvement of physiological and biochemical indices of disease. Even with said improvements, some academics have criticized cultural competence as it seems that its concern is merely to improve Western service provisions. This is the so-called one-way transaction. Authors such as Pon state that cultural competence reduces the complexity of culture to specific cultural blocks and intervention to reach and attract these cultural blocks of people that are different. This could lead to a new form of colonialism or even new racism, leaving the power of the interaction at the discretion of the professional. Let's talk about cultural safety. The term cultural safety was developed in the 1980s in New Zealand in response to the indigenous Maori people's discontent with nursing care. Again, cultural safety is an evolving term and a definition is not yet finalized. In Canada, cultural safety has been recognized by the National Aboriginal Health Organization and the Mental Health Commission of Canada as a preferred approach to guide efforts to improve the cultural responsiveness and appropriateness of healthcare. There are 4 key characteristics of cultural safety that we would like to highlight. The first one is the so-called two-way transaction. That is, cultural safety provides an opportunity for the patient to comment on practices and contribute to the achievement of positive health outcomes and experiences. It embraces the opportunity for the patient to dialogue with the physician, allowing a two-way exchange of information. This dialogue may include the patient's traditional knowledge and practices, and therefore traditional medicine. The second one is that here it is the patient who has the power to make decisions over their health. It is the patient who has the last word regarding treatment and so forth. The third one is that it is the patient who judges whether the interaction has been culturally safe or not. Finally, Cultural safety acknowledges the power imbalance, institutional discrimination, and historical colonization embedded in the Western approach to healthcare. Several authors have argued that implementing cultural safety in clinical practice would yield the benefits of cultural competence, but also affecting the legitimacy of difference and diversity in human behavior and social structure. Such a shift in practice would facilitate the transition to a more equitable and client-centered provision of health services, simultaneously reaffirming the community's right to self-determination and providing respectful services free of colonized perspectives. The last point we would like to discuss is, why is all this important for you? We hope that after finishing this course you will have examined your own reality and attitudes you bring to each new person you encounter in practice, and initiated a process conducting to be open-minded and flexible in your attitudes toward people who are different from yourself. We are interested in training a new generation of well-educated, self-aware health professionals who are culturally safe to practice, as defined by the people they serve. Ultimately, we would like to change the reality depicted in the indigenous Guatemalan women in the case study. We think that it is important to connect people's expectations and needs with healthcare training in Colombia and abroad. This will improve the quality of health services and the health and well-being of the population. Thank you for taking this course. We hope you have learned and enjoyed. See you next time.